Ankles, everyone's seen their fair share, I would imagine. If you throw your legs up here, commonly we'll do what's called a lateral ankle sprain, which is that outer part of the ankle, which is where you're sort of going over on that ankle. Okay, and I might even just draw it on here. It's all right. So there's three main ligaments on the side of the ankle. Oh no! Oh, it's going to. So there's three main ligaments there, and when the ankle rolls, you can damage one of them, two of them, or three of them in severe cases. Okay, and they tend to kind of ping in that order almost. Commonly, it's this one here on the front little sort of corner of the ankle, which is often in your sort of grade 1 sprains. Or you can have a grade 1 sprain of either really, but usually to be that when it's a bit more severe, it'll come around here, and a really nasty one and get a bit in the back as well. In doing so, in that movement where we sort of roll over, you sort of overstretch the side muscles, the side ligaments, and in doing so pinch the inner muscles. So they're the ones where it's a lateral ankle sprain, but you'll get some bruising on the side as well as the inside aspect of the ankle. Okay, and that's the reason why, is because it will pinch on the inside ligaments there too. Okay, I guess the initial management is much the same as we've spoken about. So rest, ice compression, elevation, and referral being the R on the end of the riser there. We often, if someone comes in with an acute ankle, we'll firstly sort of seek to decide whether they need an X-ray or not, which is really quite important. There's a little test that we do called the Ottawa test, which is basically where we're pressing down the lower aspect of the bone on both the outside, that outer fibular bone, and also the tibia on the inside. So we're pressing on the bony aspect there for any real sort of acute notable pain. It's a good indicator of whether someone needs an X-ray, but you sort of need to put it in context as well, because even a fairly nasty sprain can be rather tender there. So if they're not weight bearing very well, there's a stack of swelling, they're in a lot of pain, that's where we would certainly sort of look to get an X-ray. Plenty of times I've seen people for X-rays and they've come back negative, and on occasions we've seen players where they've virtually returned to training, it's where there wasn't a fracture in the has-been. So it can be a little bit dicey like that. So if in doubt, we certainly get an X-ray, and it's worth remembering that as well, so you can just handle it off and sort that out. So that's the very acute management of it. Crutches as well. I was just going to mention that sometimes that's really handy just to deload it so that they're more comfortable and they can do all of that acute management. But ultimately with ankles, we do want to get them moving ASAP. So if there's no fracture, they can tolerate it, we'll get them weight bearing straight away. And even if someone's walking with, they might be non-weight bearing initially with elbow crutches, as soon as they can tolerate in the absence of a fracture, we'll get them just touching it weight through, or at least getting their heel down and starting to sort of normalise the movement of the joint. We certainly don't have a non-weight bearing for an excessive period if it can be avoided. So in doing so, though, we obviously consider their pain and swelling as well in that way. What else? Taping, I think, is really good. Partly because it provides that bit of support for comfort, can help with the swelling, but also, again, just gets them weight bearing more normally. It allows them to weight bear comfortably, which is quite crucial. So often in the first couple of weeks, I'll tape periodically just to kind of get them through and get that going, get that joint moving. And that's where we sort of move into the phase of manual therapy, where we're starting to, much like some of the other injuries we've spoken about tonight with the corkies and so forth, where we're trying to push a bit of the swelling and so forth out of the area. So that's where, I think as Josh mentioned, effleurage wear with an ankle. That's what I was so where basically I would be, just really trying to work the swelling towards the heart away from the peripheral area. As tolerated, I suppose, because ligaments can re-bleed as well as muscles, so you wouldn't be too particularly aggressive, like Dave said, 4 out of 10 is fine, so you can pretty much get in quite safely to that extent. As things progress, we will often do more aggressive sort of frictioning through around the ligaments to really try and get rid of any scarring or thickening and ensure all the normal movement is restored. Okay. I guess my biggest thing with ankles, aside from obviously making sure there's no fractures, etc., is really sort of pushing the normal movement. There can be complications down the track. I think ankles feel really good early, so you can be 2 or 3 weeks into a healing of a ligament and it'll already feel pretty good. So a player can, want to just crack on and get on with the job, and sometimes you have to rein them in a bit and just, make sure that they're doing the requisite rehab. Mainly because, as a lot of people would know, once you've done an ankle, very common to do it again, and that's where people get caught in that cycle of, 6 weeks later doing it again, 2 months later